Hello everyone, this is Dr. Naz and the topic of today's discussion is aortic dissection. So like any other vessel in the body, the aorta also has three layers: tunica intima, tunica media and tunica adventitia, which is also known as tunica externa. Aortic dissection occurs when there is tear in the tunica intima of aorta, which results in extravasation of blood into the tunica media, which is then split into two layers, creating a false lumen alongside a true lumen. So this is a healthy vessel containing adventitia, media and intima. The rupture of intima leads to extravasation of blood into tunica media and leads to aortic dissection. The risk factors of aortic dissection includes hypertension, which is the most common cause in 80% of the cases, aortic atherosclerosis, coarctation of aorta, Marfan syndrome, Ehlers-Danlos syndrome, fibromuscular dysplasia, pregnancy, trauma, and iatrogenic, that is cardiac catheterization. So there are two types of classification for aortic dissection: Stanford classification and Debakey classification. The Stanford classification divides the dissection into A and B. A is dissection in proximal aorta and B in the distal aorta, whereas Debakey 1 involves the dissection of ascending plus descending aorta. In Debakey 2, there is dissection in only ascending aorta, and Debakey 3, the dissection involves only descending aorta. Debakey 1, which involves both ascending and descending aorta, comprises of 60% of cases, which makes it the most common one. Whereas Debakey 2 involves only ascending aorta and it comprises of 10 to 15% of cases, and Debakey 3 involves descending aorta only and it comprises of 25 to 30% of cases. Debakey 3 is also classified as Stanford B aortic dissection, whereas Debakey 1 and Debakey 2, which are involving the proximal portion of aorta, are classified as Stanford A. So men are more commonly involved than women. Peak incidence is in the 6th and 7th decade of life. Pain is the most common presenting feature of aortic dissection. If there is involvement of ascending aorta, the pain will be in the anterior chest and it will be sudden in onset and severe and tearing in character. Whereas the involvement of descending aorta will lead to interscapular pain, which will also be sudden in onset and severe and tearing. Other clinical features include syncope, that is sudden fainting, congestive heart failure features, cerebrovascular accidents, asymmetry of pulses in brachial, carotid or femoral pulse, hypertension that can eventually lead to tearing of intima, or hypotension if there is tamponade, MI and rupture. Investigations may include chest X-ray, which may show mediastinal widening due to tamponade, distortion of aortic knuckle due to accumulation of blood. Transesophageal echo can be performed. CT scan and MRI angiography are highly specific sensitive. This is a picture of loss of aortic knob. We can see on the normal side of the picture that is surrounded by a black circle that there is the presence of aortic knuckle or aortic knob, whereas on the dissection side there is loss of aortic knob. This is a CT scan, and in the middle picture you can clearly see the aortic dissection, which is pointed by yellow arrows. Type A aortic dissections require emergency surgery to replace ascending aorta, whereas type B dissections are treated medically unless there is a risk of rupture. It is also important to optimize the blood pressure. We have to keep mean arterial pressure of 60 to 75 mm of mercury and systolic blood pressure between 100 to 120 mm of mercury. The BP is controlled with IV beta blockers. First, to blunt reflex tachycardia, then decrease systolic blood pressure with IV vasodilators like nitroprusside. If beta blockers are contraindicated, then rate-limiting calcium channel blockers like verapamil and diltiazem can be used. So that's the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you so much for watching.